Sangeet, can you start your presentation?
Thank you, sir, and I thank you again for this, making me this part of this course for the first time. And I'll be speaking on surgical management of diabetic retinopathy. And before proceeding further, just a brief review of what is the surgical anatomy in diabetic retinopathy. We all know that new vessels grow along the arcades using posterior hyaloid as a scaffold, and then they progress to fibrovascular and contractile epiretinal membranes. And these membranes again grow and contract to give rise to tractional retinal detachment. And increasing traction, with increasing traction, the breaks develop and they lead to combined rhegmatogenous and tractional retinal detachment. And if this traction is more on retinal vessels, those retinal vessels may rupture and cause vitreous hemorrhage. And it is difficult to treat these membranes, and the difference from the retinal detachment is basically that these membranes are not glued and you just can't pull on these membranes, but they are sort of nailed at multiple epicenters of neovascularization. And you have to go around those new nails to remove all this growing tissue. And various indications for vitrectomy in diabetic retinopathy include non-clearing vitreous hemorrhage, macula-threatening tractional retinal detachment, combined retinal detachment, neovascular glaucoma. In early stages when you have to do removal of vitreous hemorrhage earlier, severe PDR when your diabetic retinopathy is not responding to your pan-retinal photocoagulation, and there's still growth of new vessels even after doing maximum pan-retinal photocoagulation. Subhyaloid hemorrhages, you have to go in early. And in diabetic macular edema, whether it is recalcitrant, tractional, or subfoveal hard exudates are present. So the various goals or the various steps of doing vitrectomy in diabetic retinopathy include, first of all, is to clear the media opacities. This video is not playing.
Yeah. Can you address the issue of video not playing?
Yes, no, it's. So first thing is to clear the media opacities, you remove all the vitreous hemorrhage or the subhyaloid hemorrhage, and once these media opacities are clear, you get a good view, then you create a plane of dissection. I prefer to start my dissection at the optic nerve head, just remove the membrane from the optic nerve and you get a good plane of dissection. And you proceed with the dissection of membranes, you cut around all these vascular epicenters one by one. You can do desegmentation, one by one you remove all these membranes, and delamination. And with the cutter you can do both the things at the same time. And then if there is a tractional retinal detachment or combined retinal detachment, you have to settle the retina, then do ILM peeling if it is needed. Laser the retina, give a good photocoagulation to prevent recurrences of vitreous hemorrhage after surgery, and in the end you give a tamponade. And you have to be wary of the vitreous cases which may be present in these eyes, which is very common. And after you have to remove all the membranes and identify all the membranes before you close the case. So coming to the vitreous hemorrhage now, we do mostly in non-clearing vitreous hemorrhage, though the DRBS recommended 6 months waiting period. But nowadays with the better instrumentation and better machines, we are now going in early. Some surgeons prefer to go as early as 6 weeks. But if there is a concomitant RD or a new vascularization of the iris, or it's a type 1 diabetes mellitus or subhyaloid hemorrhage or a hemolytic glaucoma, you need to go in early. And this is how in vitreous hemorrhage, in severe vitreous hemorrhage, you make a hole in the peripheral vitreous and then you remove, this is called a skirting technique. Then you just proceed either posteriorly or circumferentially, just keep on enlarging the hole all around. And this way you can remove all of the vitreous hemorrhage without causing damage to the underlying structures. So here, simultaneously, I'm moving posteriorly as well as I'm going circumferentially. So once this hole is created, then you are safe, you know what is lying below, and you can slowly increase the perimeter of your cutting. So this is what is called the skirting technique. And sometimes you will have this subhyaloid hemorrhages, and the trick is to just make a small hole here posteriorly, and through this small hole you try to remove all this hemorrhage, all possible hemorrhage, Because if you make a larger hole here, the whole of this blood will come into the vitreous cavity and will impede your view, and you'll have to spend a lot of time clearing the media after this. So through a small hole, remove all this blood, and then you proceed ahead with your surgery. So for retinal detachment, especially in the TRD threatening the macula or the combined retinal detachment, one thing we often use is for these largely vascular membranes, we give a anti-VEGF 3 to 4 days before routinely. And this was the patient who went anti-VEGF 1 day post-operatively. And you see the membrane vascularity has decreased markedly, and you can proceed with your vitrectomy without any fear of bleeding during the surgery here. Again, you can see you segment this new vascular epicenters one by one, and you keep on dissecting them one by one. Also, you can use the proportional reflex, which is present nowadays in the vitrectomy machines, to elevate these membranes and create some space for dissection. Here I'm using this proportional reflex to just create some space and then dissect these membranes. This is the post-op, and this is another patient with combined retinal detachment. Again, in this patient, I just went ahead, created a plane of dissection by removing the membranes at the optic nerve head, and then I created a wedge connecting the central retina with the peripheral retina, and now I am inducing the PVD in the peripheral retina, and this way you can go from to remove the membrane from all the sides, and it becomes easier. So what I generally do, I call this a round the table dissection. So from both sides, you can take up the membrane, not inside out or outside in. In this way, you can go both outside in and inside out whenever you please to do it. So this is 1 year post-operative, the same patient. Bimanual peeling is very helpful in very thick and highly vascular membranes in thin retina, or if you're not able to start your membrane dissection at the disc. And for this, this was a 46 years male. Female best corrected vision was hand movements. She was one-eyed with PDR and tabletop TRD. Again, my method of doing bimanual dissection includes I generally use a homemade chandelier. I remove this metallic strip over the old light pipes, and then I cut this is stripped off, and then it is cut from the middle, and then it can be used as a chandelier. And this is the same patient, how we proceeded for surgery. I for my way, is using a longer 1-inch 25 gauge needle. And you can just hold up the membrane, and with this needle, you can cut at the vascular epicenters. And similarly, this can be used to delaminate the membrane as well. So one by one, all these vascular epicenters were removed. And once you reach the optic disc, you know now that you can remove the membrane from the optic disc and proceed further with your vitreous cutter or with the scissors if you may like, as such. So this way, with the needle, I now, when you have some difficulty, you can use either a scissor or a cutter to cut these membranes. But this is what you do. But you do whatever you feel like. But one by one, all these vascular epicenters need to be removed. So this is the 3 months post-operative. The best corrected vision had improved to 6.9. Coming to diabetic macular edema, we generally do vitrectomy if your diabetic macular edema is not responding to your traditional treatments, or as Dr. Vishali pointed out, in patients with attractional macular edema or with taut posterior hyaloids. Some people have advocated using a primary vitrectomy for non-tractional DME also. And if you have very high plaque-like soft foveal exudates, so these are some pre and post pictures of vitreomacular traction. You did a vitrectomy and the patient settled. This is a patient in which there was an epiretinal membrane in a diabetic case, and you have to do a vitrectomy as a primary procedure here. And this is the patient with diabetic macular edema with subfoveal exudates, in which the exudates were increasing despite multiple injections. And in this, the vitrectomy was done and the patient improved. Thank you.
Very much, Sangeet. Actually, it is very clear and crisp. One message clearly we want to send is what cases you had showed as a before surgery. Some may think that it is not doable.
What's it?
Some may think that it is not doable and they may explain the prognosis. I urge all the delegates that they should refer these cases to at least one of the vitreoretinal surgeries. And a lot of means cases where you think it is end stage, it is not really end stage, and we can still revive the vision in these patients. Thank you for showing that very clearly. We have two issues which during our all presentations which were not addressed completely is one, diabetic retinopathy with vitreous hemorrhage.
Yes.
Where a lot of people tend to inject. The patient comes and I was advised injection. Vishali, can you highlight when to inject? If you are injecting, how to follow these patients?
I think if there is a vitreous hemorrhage which is dense enough, yes, 1 minute.
Almost over. Yes.
Done. And you cannot visualize, injections is not going to help. If it is previously lasered patient and you can see the part of retina nicely and it's just the mild to moderate vitreous hemorrhage, then injection might help. And if it is not lasered mild hemorrhage, you do inject, but then you have to do laser promptly as the hemorrhage resolves.
Thank you very much.
One
Vishali,
more
there is-
indication I would like to say is that vitreous cavity hemorrhages, if you are having recurrent, you can use injection as a good
Yes,
option
yes,
in
yes.
those cases.
That is as a temporary option, not a permanent.
You can, so you can do as a treat and extend. You
Yes,
can
yes.
keep on injecting and extending the treatment. And